Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession. I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services, so I humbly urge you to sit back and spare me part of your very precious time to share with you some of the precious tips which may prove useful in your line of duty. Welcome to part 45 of our pharmacotherapy MCQ series. Question 1 reads, your team is managing Mr. DOM, a 40-year-old male patient with known alcoholic cirrhosis as an outpatient for the prevention of hepatic encephalopathy using lactulose. So my question to you is, how best should lactulose be administered to Mr. DOM? Should you titrate the dose to a blood ammonia level of at least 10 or less micromoles per liter? Or should you titrate the dose to produce no more than 2 to 3 loose stools daily? Or would you consider adjusting the dose based on stool ammonia levels? Or would you administer 300 ml of lactulose rectally every day? I'll give you 10 seconds to choose the correct answer. I would opt to titrate the dose to produce no more than 2 to 3 loose stools per day. Now, when using lactulose for preventing hepatic encephalopathy, which is abbreviated as HE, from alcoholic cirrhosis, the lactulose is administered orally and the dose is titrated to produce no more than 2 to 3 stools per day, and that is mainly to avoid precipitating volume loss, because that would cause the patient to go into either type 1 or type 2 hepatorenal syndrome, which we abbreviate as HRS. Lactulose isn't titrated to a specific blood ammonia level at all. It doesn't appear in any guidelines. Now, rectal lactulose is administered primarily for acute hepatic encephalopathy, where, for example, a patient may have an altered mental status, because that would make oral administration more difficult due to the high risks of aspiration. Now, we don't need to measure ammonia levels in stool in common clinical practice, and we do not titrate lactulose based on this at all. Lactulose causes the conversion of ammonia to ammonium ions, and we know that ammonium ions cannot cross to the bloodstream. Therefore, this facilitates fecal elimination of the excess ammonia. Now, just like to add that type 1 hepatorenal syndrome patients have greater rise in serum creatinine, and this happens over a shorter time than the type 2 cases. I would also like to remind you that type 1 hepatorenal syndrome is associated with a greater risk of mortality than type 2. Just as a by the way, let's move to the next question, please. And it reads, Mr. JTM, a 56-year-old man, has decompensated cirrhosis. He is admitted to the medical ward in your hospital with tense ascites. He has been reviewed several times in the last half a year for similar complaints, and has been appropriately managed by your gastroenterologist using an optimal regimen of sodium restriction and oral diuretics for 90 days. And in addition to that, he's also added other therapies. Now, this patient reports good adherence to his regimens, and apart from ascites, he denies any other complaints. He's not nauseated, he doesn't vomit, he doesn't diarrhea, there is no hematemesis, no melena, no chest pain, no shortness of breath. Neither does he have palpitations or fever. And his gastroenterologist has diagnosed him with refractory ascites and has consulted you to optimize his pharmacotherapeutic regimen. We are told the abdomen is protruding and distended, and there's a positive fluid wave, and there's shifting dullness. Now, the extremities are both edematous, the lower extremities, and there's also sacral edema. And some of the pertinent admission lab values include sodium levels of 127, potassium of 4, a BUN of 30, creatinine of 1.9, total bili of 4, AST of 45, ALT of 50, GGT of 28, and an albumin of 1.2, and the ammonia level is 25. So would you choose to discontinue spironolactone and furosemide, or would you discontinue nadolol, or would you initiate midodrine at a dose of 7.5 milligrams orally thrice a day, or would you initiate 25 grams of IV albumin once weekly? I'll give you 10 seconds to choose the correct answer. Both answers B and C are correct. Now, while beta blockers play a significant role in patients with gastroesophageal varices, the risks versus benefits profile must be considered in patients with refractory ascites, and systemic hypertension may limit their use in the setting of a refractory ascites when intravascular volume is displaced. So we have to use them with care. Now, some evidence suggests they may worsen survival in such patients. Now, in the setting like this one, the appropriateness of their therapy must be closely evaluated to avoid complications during therapy. Now, midodrine is a systemic vasoconstrictor. To be specific, it's an alpha-1 adrenergic agonist, which increases arteriolar and venous tone. Clinical trials in those with recurrent or refractory ascites have shown positive clinical outcomes of increased urine volume in such patients. They have also shown increase in mean arterial pressure and even survival. Now, midodrine, when added to a diuretic regimen, can increase blood pressure and convert refractory ascites back to diuretic sensitive ascites, and it should be considered. So I would be biased towards answer C. And I would just like to add that first line therapy for ascites includes abstinence from alcohol if liver injury is alcohol related. It can also include dietary sodium restriction to less than 2 grams per day. It can include oral diuretics, and we majorly use spironolactone with or without furosemide. Now, diuretics increase urinary excretion of sodium to promote fluid loss and weight loss. Remember, as we lose sodium, water follows sodium. There is often hesitation in giving diuretics to hypotensive patients who are ascitic. But maintaining this regimen is key in intervening the pathophysiology of ascites. In some cases, diuretics may require discontinuation if other parameters are optimized and there is still insufficient response to the diuretic regimen that you are using. And I would just like to add that there is limited evidence indicating improved survival in patients with new onset ascites who require weekly infusions of albumin in addition to the diuretics, that is spironolactone and furosemide. However, this evidence is limited to those with new onset ascites only. Now, refractory ascites is defined as fluid overload that is unresponsive to a sodium-restricted diet and a high-dose diuretic treatment, or one that recurs rapidly after therapeutic paracentesis. Treatment refractory ascites is a fine balance of limiting agents that may worsen hypotension, such as beta blockers, the ACE inhibitors, while maintaining agents that intervene on the pathophysiology of ascites, such as diuretics, spironolactone and furosemide to be specific, and even those that help optimize blood pressure, and also those that encourage conversion to diuretic sensitive ascites, such as midodrine. I'd just like to add that if diuretic resistance persists despite optimizing of medical therapy, various medical and surgical procedures can be considered. Now, diuretic failure may be defined as minimal to no weight loss, or inadequate sodium excretion, or development of diuretic-related complications of diuretics such as serum creatinine greater than 2 milligrams per deciliter, serum sodium levels less than 120 milliequivalents per liter, or even serum potassium greater than 6 milliequivalents per liter. Those are just, by the way, points. Let's move to the next slide, please. Mr. KMK, a 66-year-old male with decompensated cirrhosis, presents to your accident and emergency department with tense ascites. He was lost to follow-up despite having had similar experiences in the past. He denies nausea, vomiting, diarrhea, hematemesis, melena, chest pain, shortness of breath, palpitations, or fever. 7 liters of ascitic fluid is removed by the clinical team at your hospital. So my question to you is, what would be the best next course of intervention in this patient's case? He has pertinent admission physical examination such as height of 5'7", weight of 98, and his weight 30 days ago was 85 kilos. That is self-reported. Today he has a systolic blood pressure of 96, diastolic 60, a heart rate of 102, a respiratory rate of 16, a temperature of 98 degrees Fahrenheit, and he's alert and oriented. And his mucous membrane is yellow and dry, and the white part of the eye is yellow. Yeah, they have detected icteric sclera. On doing GI examination, the abdomen is protruding, distended, and there is a positive fluid wave with a shifting dullness. Both lower extremities are edematous. There is also sacral edema. He has a sodium level of 129, potassium of 3.5, a BUN of 28, creatinine is 2.2, total bili is 3.6, AST is 50, LT is 30, GGT is 35, albumin is 1.5, and the ammonia level is 28. So, would you consider fluid restriction? Would you infuse albumin? Would you administer tolvaptan orally? Or would you co-administer spironolactone and furosemide orally? I'll give you 10 seconds to choose the correct mode of intervention. I would choose to infuse albumin. Now, due to a loss of synthetic function in cirrhosis, which includes a reduction in albumin production, there is an imbalance in hydrostatic and oncotic forces. And this contributes to the pathophysiology of ascites and other cirrhosis-related complications in such patients. Therefore, in the setting of large volume paracentesis, whereby greater than 5 liters of fluid are removed, albumin at a dose of 6 to 8 grams per liter removed is recommended, and it has some mortality benefit according to literature out there. Now, performing a large volume paracentesis without albumin replacement can result in paracentesis-induced circulatory dysfunction, and other complications may also occur as intravascular fluid actually rapidly leaks back into the peritoneum. That can complicate issues for the patient. Now, fluid restriction has limited utility in the setting of ascites related to portal hypertension. While fluid restriction has utility in some hypervolemic states, in patients with ascites due to portal hypertension, sodium balance is critical in the maintenance of optimal fluid balance. Now, we know that fluid passively follows sodium. Therefore, restriction of dietary sodium to less than 2 grams daily helps mobilize fluid and optimize fluid balance and weight loss. Now, fluid restriction may play a role when serum sodium is less than 125 milliequivalents per liter. However, chronic hyponatremia is pretty common with cirrhosis and rarely causes complications unless unjudiciously corrected in magnitude and if it's done very fast. Now, I'd just like to comment that the vaptans, tolvaptan or conivaptan or vasopressin receptor antagonists, result in secretion of free water without loss of electrolytes. Now, while they are effective in treating hyponatremia, there is a paucity of evidence using them in the setting of cirrhosis. They work rapidly and may cause unfortunate complications if serum sodium is altered too rapidly. They can make complications for the patient, and they require very, very close supervision, and another downside is that they are very costly. In my opinion, benefits here do not outweigh risks, so I would not settle for tolvaptan. I'd just like to remind you that first-line therapy for ascites includes abstinence from alcohol if liver injury is alcohol related. Then there's also dietary sodium restriction to less than 2 grams per day, and even oral diuretics, furosemide and spironolactone to be specific, also have a role to play. Now, abstinence from alcohol allows for improvement in reversible components of alcohol-induced liver disease. Now, because fluid passively follows sodium, dietary sodium restriction can mobilize acidic fluid, but adherence may be an issue. It's very difficult to eat saltless food, so very few people would adhere. Now, diuretics increase urinary secretion of sodium to promote weight loss. Now, adherence to diuretics may be greater as it allows more freedom in dietary sodium intake. I'd just like to add that patients with cirrhosis commonly have chronic hyponatremia, which doesn't usually display symptoms until serum sodiums fall below the 110 milliequivalents per liter mark, or if the decline in serum sodium is rapidly done. Now, paracentesis is both a therapeutic and diagnostic option in the management of this condition we call ascites. I would just like to add that it doesn't correct the underlying pathophysiology leading to the development of ascites. Now, while it may provide symptomatic relief, other interventions such as the use of diuretics must be administered or implemented. Otherwise, paracentesis alone would not do the trick. Let's move to the next question, please. Mr. QHM, a 44-year-old male with known cirrhosis and no known drug allergies, presents to your hepatology clinic with abdominal distension and pain. And this is possibly due to spontaneous bacterial peritonitis that we abbreviate as SBP. Now, your clinical team performs a paracentesis which shows an SAAG above 1.1. Now, that SAGG is the difference between serum albumin and ascites albumin. And an if I may digress a bit, an SAAG that is above 1.1 grams per deciliter indicates portal hypertension and suggests a non-peritoneal cause of ascites. So we are told the SAGG is above 1.1 and an ascitic neutrophil count value of 263 cells per microliter is obtained. So my question to you is, which of the options listed below would be the best empiric treatment for Mr. QHM now? Would you opt to infuse 2 grams of ceftriaxone once a day? Would you choose to infuse 1 gram of cefazolin over 30 minutes twice daily? Or would you choose to infuse 2 grams of cefotaxime thrice daily and co-administer 1.5 grams of albumin per kilo body weight today and then on day 3? Or do you feel no antibiotic treatment is indicated in this patient at this time? I'll give you 10 seconds to choose the correct answer. So in my opinion, C is the correct answer. Now, QHM meets the basic criteria concerning SBP, which includes abdominal pain with ascites, SAAG value above 1.1 grams per deciliter, and an ascitic fluid neutrophil count of above 250 cells per microliter, and thus he warrants antibiotic treatment with supplemental treatment with albumin at the time of diagnosis and on day 3 to be specific. Now, in my opinion, alternative B, cefazolin, isn't recommended treatment option due to its insufficient coverage of the gram-negative organisms. Remember, E. coli and Klebsiella are very common causative pathogens in this SBP. Now, ceftriaxone and cefotaxime are both third-generation cephalosporins that provide adequate coverage against E. coli and against Klebsiella pneumoniae. Now, albumin should be added to antibiotic coverage to help prevent the risk of renal impairment and potential type 1 and type 2 hepatorenal syndrome. And those we know can worsen this patient's condition and cause mortality. I would just like to remind you that ceftriaxone, ertapenem, and cefotaxime are considered first-line options for spontaneous bacterial peritonitis. Now, patients with esophageal variceal bleeding should be given ceftriaxone or norfloxacin or ofloxacin for 7 days to prevent SBP and to improve their survival. That's just a by the way. The next question reads, Mr. FSO, 55-year-old male, is admitted to the general medical ward in your hospital with bilateral lower extremity edema and rails on physical examination. His past medical history includes heart failure with reduced ejection fraction. He's hypertensive. He has suffered an MI before. He has an atherosclerotic cardiovascular disease, and he has bilateral osteoarthritis on both knees, to be specific. Currently, he takes 40 milligrams of lisinopril orally once daily, 40 milligrams of furosemide once a day, 12.5 milligrams of carvedilol twice daily, 40 milligrams of atorvastatin at bedtime as his high-intensity statin therapy, and he also takes 500 milligrams of naproxen for his osteoarthritis. And to counter the effect of the NSAID, he also takes a PPI, omeprazole, at a dose of 20 milligrams orally once daily. On admission, IV furosemide is administered at a dose of 40 milligrams IV 4 times daily without significant improvement in diuresis or volume status. All his other medications were also resumed. So my question to you is, which of the therapeutic plans listed below would improve Mr. FSO's status the most? Would you choose to discontinue metoprolol or add 5 milligrams of metolazone half an hour prior to furosemide, or would you discontinue naproxen, or would you opt to change furosemide from IV to a continuous infusion? I'll give you 10 seconds to choose the correct answer. I would opt to knock off the naproxen. Now we know that precipitating causes of an acute worsening of heart failure should be identified and managed promptly, e.g. the introduction of drugs which impact the neurohormonal regulation of sodium and water balance within the kidneys. Now, NSAIDs such as naproxen can potentially impact sodium and water balance and reduce the effect of loop diuretics like furosemide through the disruption of prostaglandin synthesis, which we know that helps mediate renal blood flow. Now, the addition of a thiazide or a thiazide-like diuretic, like metolazone, in my opinion, is a common approach to augment inadequate diuresis in those with refractory heart failure or in diuretic resistance. Now, loop diuretics work by blocking the absorption of sodium and chloride in the ascending loop of Henle. The kidney may compensate by increasing the absorption of sodium and chloride downstream in the distal tubule. Now, the addition of metolazone to furosemide is thought to prevent the enhanced reabsorption of sodium and chloride, and in that way it promotes diuresis. Now, while this would be a potentially effective strategy, identifying and eliminating any precipitating factors should be our first step. We should not be too quick to add metolazone onto that therapy. Now, IV loop diuretics like furosemide are the mainstay in treating heart failure patients admitted with fluid overload. According to the guidelines, doses should be equal to, or they should exceed chronic daily doses, which can be given as intermittent boluses or as continuous infusion. Now, when diuresis is inadequate, a common approach is to change a bolus regimen to a continuous infusion. And however, evidence doesn't support superiority of continuous infusion over intermittent boluses when given at sufficient doses. Now, a patient's outpatient medications warrant a close review upon admission, because there would also be drug-drug interactions that are compromising clinical outcomes. Now, in most cases, guidelines direct medications should be continued during hospitalization. Now, while initiation of beta blockers such as metoprolol in an acutely decompensated state isn't recommended, if a patient was previously stable on them, then I would not have a problem with that. Continuation of the beta blocker would be recommended. Now, we know that metoprolol was not there in the first place, so that is just to confuse you. And then medication and adherence and initiation of new medications and drug-drug interactions or drug-food interactions can also precipitate an acute decompensation in heart failure. So we have to look at the global picture when managing such patients. But in my opinion, discontinuation of the NSAID, naproxen, would give us the best outcome in this particular case. Let's move to the next question, please. Mr. D.A.M., a 46-year-old Hispanic male, is brought to hospital by an ambulance and he is delivered to your A&E. He has a past medical history of alcoholic cirrhosis, type C. He also suffers from recurrent hepatic encephalopathy, and you are told the family found him lying on the couch with confusion and difficulty to follow instructions. He had an altered mental status. Now you are told he stopped his lactulose 2 weeks ago, and his last meal was hamburger from McDonald's yesterday, laden with red meat, a lot of protein, a source of ammonia. Now the vitals include the fact that he's stable, he's afebrile, and a point of care glucose test is done, which shows normal glucose levels. This is not a diabetic patient. And the labs show ammonia levels of 96 millimoles per liter, pretty high. The question to you is, which of the treatments listed below would be the next best mode of intervention in Mr. D.A.M.'s case now? Would you opt to administer 4 grams of neomycin orally every 4 hours? Or would you administer rifaximin at a dose of 400 milligrams thrice daily orally? Or would you administer 200 milligrams of lactulose via a rectal balloon catheter with retention for about half to 1 hour? Or would you administer 30 milligrams of lactulose orally every hour until this gentleman starts to have loose stool? I'll give you 10 seconds to choose the correct answer. So I would opt to administer the lactulose rectally. Now, any patient considered to have an altered mental status where there is confusion and difficulty following commands puts that patient at a risk for aspiration when trying to administer any form of medication orally. Now, medications can be administered by other routes rather than the oral route, considering this potential safety concern. Now, once the patient's ammonia levels start to clear and the mental status improves, he can be switched back to an oral dosage formulation or treatment. Now, patients with cirrhosis and non-recurrent hepatic encephalopathy can have acute exacerbations when ingesting large amounts of protein, such as this gentleman who had a big hamburger. Yeah, we know that from such red meat, like the one in the hamburger, that could be a contributing factor. It contributes a very large ammonia load, and that can overwhelm the liver's urea cycle. That is a source of this gentleman's problem. Let's move to the next question, please. It reads, Mr. FKO, a 48-year-old male patient with moderate cirrhosis and a recurrent ascites, presents to your hepatology clinic. According to your protocols, he is a candidate for diuretic therapy containing spironolactone and furosemide to prevent his ascites from accumulating so soon after a recent large volume paracentesis. So my question to you is, which of the statements below is true concerning the use of diuretics in ascites? Is it true that spironolactone is being used in low doses to create balance in potassium that is lost from furosemide? Or is it true that furosemide is being used to cause greater diuresis to facilitate fluid removal faster? Or is it true that the dose of spironolactone is adjusted to increase urine sodium excretion to above 78 millimoles per day? Or is it true that the most common ratio of spironolactone to furosemide dosing is 50-50? I'll give you 10 seconds to choose the correct answer. Personally, I would settle for answer C. The dose of spironolactone is adjusted to increase urine sodium excretion to more than 78 millimoles per day. Now, the most common ratio of spironolactone to furosemide dosing is usually 100-40, and this can be increased all the way to doses of 400 to 160 daily. Now, the larger doses of spironolactone are required because due to the excessive activation of the renin angiotensin aldosterone system, what we call the RAS, because of the low oncotic pressures encountered in cirrhosis, which create fluid movement into the tissues, thereby causing hypoperfusion of the nephron, we have such a scenario. Now, the lower dose of furosemide is added to prevent or to offset the risk of developing hyperkalemia. Remember, spironolactone is potassium sparing, given the large doses of spironolactone being used. Now, furosemide causes potassium loss, you can call it potassium wasting in quotes, through a mechanism of inhibition of the sodium, the chloride, and the potassium co-transporter in the thick ascending loop of Henle. Now, when the appropriate dose of spironolactone is being used to block the RAS, the nephron stops reabsorbing so much sodium due to the excessive levels of aldosterone that accumulate, thereby increasing the renal sodium excretion. And we know that water always follows sodium, so you end up being a lot and losing part of the ascitic fluid. Now, too much diuresis can put the patient into hepatorenal syndrome, and thus it warrants close monitoring and careful titration of diuretics. Don't just overdose carelessly, otherwise there would be problems. You'd end up with hepatorenal syndrome, HRS. Let's move to the next slide, please. Mrs. J.O.Z., a 43-year-old female, presents to the hospital with mild shortness of breath associated with worsening ascites. She is known to suffer from alcoholic cirrhosis, and during this visit she denies fever, nausea, vomiting, and she's able to answer questions appropriately. So she doesn't have an altered mental status. In the opinion of the clinical team, paracentesis is imminent. So my question to you is, how much ascitic fluid can your clinical team drain before IV albumin is indicated to help prevent what we call paracentesis circulatory dysfunction? Is it after 5 liters, after a liter, up to 3 liters, or none, because albumin isn't indicated and no evidence supports its use in this particular situation? I'll give you 10 seconds to choose the correct answer. Five liters it is. Now, a meta-analysis involving 1,225 patients in 17 trials showed that albumin supplementation reduced the incidence of post-paracentesis circulatory dysfunction. It also reduced the incidences of hyponatremia and even possibly reduced mortality in these patients. Now, the AASLD guidelines. AASLD stands for the American Association for the Study of Liver Disease. Those guidelines recommend 6 to 8 grams of albumin per liter drained over 5 liters to avoid risks of post-paracentesis circulatory dysfunction. I would just like to add that post-paracentesis sodium restriction is usually set at 2 grams per day or 88 millimoles per day. So let's move to the next slide, please. It reads, Mrs. GSM, a 46-year-old female who regularly visits your hepatology clinic, has chronic ascites and recurrent spontaneous bacterial peritonitis, what we abbreviate as SBP. Your clinical team decides to discharge her home on SBP prophylaxis after this particular visit. So my question to you is, which of the regimens listed below would be suitable for spontaneous bacterial peritonitis prophylaxis in Madam GSM's case? Would it be 500 milligrams of ciprofloxacin once a day orally? Would it be 500 milligrams of dicloxacillin taken orally twice a day? Or would it be 400 milligrams of norfloxacin taken orally once daily? Or would you settle for trimethoprim sulfamethoxazole double strength, 1 tablet once daily orally? I'll give you 10 seconds to choose the correct answer. So I would opt for A, C, and D. Now, all the listed microbials or antibacterial agents, with an exception of dicloxacillin, can be used in secondary prophylaxis of SBP in patients with chronic ascites and or recurrent spontaneous bacterial peritonitis. Now, prophylactic antibiotics should have sufficient coverage for the gram-negative pathogens such as E. coli and Klebsiella pneumonia, at least, since they are more likely to cause spontaneous bacterial peritonitis. Now we know that dicloxacillin is a penicillinase resistant penicillin that has a narrow spectrum of activity. It basically targets MSSA, and it would be no match for E. coli and Klebsiella pneumo that are common causative pathogens in SBP. So it would not be a good choice. Now, secondary prevention against SBP in patients with chronic ascites and or recurrent SBP can be treated with ciprofloxacin, with norfloxacin, or even with trimethoprim, sulfamethoxazole, just as a by the way. Let's move to the next question, please. And it reads, in which of the conditions listed below does albumin have a potential therapeutic role? Is it in hepatorenal syndrome, in spontaneous bacterial peritonitis, in ascites, in hepatic encephalopathy, or is it in gastroesophageal variceal hemorrhage? I'll give you 10 seconds to choose the correct answer. So both answers A and B are correct. Now, spontaneous bacterial peritonitis is an acute bacterial infection of the ascitic fluid that is associated with a high mortality. Don't take it lightly at all. It is a poor prognostic sign and is immediately life-threatening. Now, analysis of the ascitic fluid through abdominal paracentesis is a helpful way of diagnosis of SBP, and diagnosis of SBP may be made when polymorphonuclear lymphocytes, the PMN, count within the peritoneal fluid exceeds, if I remember well, the 250 cells per microliter mark. It can also be made when there is no evidence to support any intra-abdominal infection from another source, when the PMN value is at that figure. Then I would like to add that patients with a PMN count of equal to or above the 250 cells per microliter mark with a clinical suspicion of SBP and with the criteria that I'll mention below, such as a serum creatinine of less than of above 1 milligram per deciliter, or a BUN above 30, or a total bili above 4, have a chance of improved survival when albumin is co-administered. Now, in addition to appropriate antibiotics, it's recommended we give them 1.5 grams per kilo body weight of albumin IV within 6 hours of detection of this SBP. And by day 3, we should administer 1 gram per kilo of the same albumin. That is a recommendation in guidelines. Now, hepatorenal syndrome is a kidney injury in the setting of cirrhosis in the absence of any other intrinsic kidney disease, and it results from the widespread neurohormonal dysregulation, which is associated with portal hypertension, and it can also be associated with cirrhosis. It can be classified as either type 1 or type 2, and its treatment consists of vasoactive drugs that intervene on the neurohormonal dysregulation. It also includes albumin and even supportive measures. Now, the goal is to maintain function and to provide supportive care until liver transplantation can be performed, unfortunately. Now, loss of albumin synthesis, which is the main constituent of oncotic pressure, contributes to the development of ascites. Now, while the mainstay of therapy in such patients is abstinence from alcohol if liver injury is alcohol related. It can also be dietary sodium restriction to less than 2 grams per day, and even oral diuretics can be used. Large volume paracentesis, that is to say greater than 5 liters of fluid being removed at a go, may also be warranted, and in such cases albumin must be dosed at a dose of 6 to 8 grams per liter removed if we are to avoid complications, because this has been shown to have some mortality benefits. Now, performing a large volume paracentesis without albumin replacement can result in what we call paracentesis-induced circulatory dysfunction and many other complications, since intravascular fluid rapidly leaks back out into the peritoneum, and we'll be back to square A where we are. Now, currently there is no evidence supporting the use of albumin in the management of hepatic encephalopathy, nor in the management of gastroesophageal variceal hemorrhage. We restrict its use to ascites. Let's move to the next question. It reads, Mr. SWM, a 49-year-old man with cirrhosis, who is regularly followed up at your hepatology clinic, presents to your hospital today. He has been maintained for a long while on an optimal regimen of sodium restriction and diuretics, that is spironolactone at a dose of 400 milligrams orally once daily, and furosemide at a dose of 160 milligrams orally daily, to be specific. And he reports good adherence to his regimen, but he states that he misses approximately 3 doses of his medication in a month. Now, at a recent visit, he reported tenderness and swelling of his breast tissue. Now, the gastroenterologist suspects gynecomastia is setting in. So my question to you is, what recommendation would you make concerning Mr. SWM's regimen now? Would you choose to continue furosemide and substitute eplerenone for spironolactone, or would you continue furosemide and substitute amiloride for spironolactone, or would you choose to discontinue spironolactone and use furosemide monotherapy, or would you reduce the doses of both diuretics? I will give you 10 seconds to choose the correct answer. I would substitute the spironolactone with amiloride, and I'll tell you why. According to guidelines, amiloride, which is another potassium-sparing diuretic, can be substituted for spironolactone in patients who develop bothersome gynecomastia. Now, eplerenone, though it belongs to the same class as spironolactone, has only been studied in the setting of heart failure, and it doesn't currently have any evidence to support its use in the management of ascites, so I would shy off from it. Now, a dual diuretic regimen is used to promote more rapid natriuresis and maintain normal kalemia. Now, while spironolactone may be used as monotherapy in select patients, furosemide isn't recommended as monotherapy because it is less efficacious. So that makes answer C wrong. Now, spironolactone-induced gynecomastia is a dose-related and a duration-related adverse event, and it has an incidence of greater than 50% in doses of 150 milligrams per day or more. Now, while reducing the dose may be an option, a dose reduction in someone who was previously controlled may be deleterious to the control of this ascites. So I would not go there. I would not opt to reduce the doses. That makes answer D wrong. Then I would like to add that spironolactone blocks the production of androgens. It also blocks androgen binding receptors, and it creates an imbalance between testosterone and estradiol by displacing estradiol from receptors and increasing peripheral conversion of testosterone to estradiol. Now, spironolactone-induced gynecomastia is usually reversible upon discontinuation of spironolactone therapy. So I would opt to switch it with amiloride for better outcomes, and that would get rid of the gynecomastia. So, ladies and gentlemen, my highly esteemed viewers and listeners, that brings us to the end of part 45 of our pharmacotherapy MCQ series. If this video benefited you in any way, I would like to remind you to please give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. Now, I would like to thank you very much for viewing it and for listening to me. I sincerely appreciate your partnership and your continued support and kind collaboration with me. So I look forward to interacting with part 46 of our pharmacotherapy MCQ series. Thank you for always being there for me.